the data leads for PEDSnet projects, either arising from your institution or from other institutions. So welcome to session 1 for that one. This is on the data models and vocabularies. Can I get you to click ahead for me? Yep, welcome to session 1. So briefly today, what we want to do is talk through the data model that we use in PEDSnet to store the network data and the terminologies that are used to represent those data. As the folks on the call who have been involved with the ETL for the network know well, we use a data model that is both semi-denormalized to focus on representation of common clinical concepts and has strong terminology harmonization so that we can level out some of the differences in the ways a given concept may be represented in different places. We'll talk through some of the key domains of that data model and how the way the data are represented goes into trying to get at particular kinds of information and some of the additions that PEDSnet has made. So let me just start for folks that have not been as involved in the past in the nitty-gritty with where these data modeling concepts come from. So I'm going to start from the perspective of the Data Coordinating Center at PEDSnet. Right now, that Data Coordinating Center is a team of people at CHOP. Our goal is to develop what we call the Center Without Walls. So this is a team that is based at any PEDSnet member institution. The DCC is responsible for 4 functions, right? Moving data from place to place securely, modeling the data, deciding how we're going to represent it, and that's done in conjunction with the data committee. Making sure that the data that we have are as functional as we can get to, and that's done obviously in conjunction with the folks at each site. And then the focus of today's work, providing data science support for various studies. So it's common that we are working with investigators who are very capable epidemiologists or health service researchers, but don't have a lot of experience dealing with EHR data. They may be grounded in claims or don't have experience dealing with the data model. And so we're working with them to try to help them make the best use of the data available. Right. Again, not news to the folks involved in ETL, but briefly, the data that we use are extracted at each site, and a lot of the transformation happens at each site. Then it gets merged in the Data Coordinating Center in a common data model. We use the OMOP-based PEDSnet CDM. PEDSnet uses the Sentinel-based PEDSnet CDM, and part of our pipeline responsibility is to transform back and forth between the two. So what's the point of this? Fundamentally, it's that data exists in lots of clinic or EHR or purpose-specific representations. The same concept is represented in different ways in different places, and it becomes infeasible rapidly to change the way you look for data or the way you represent it every time you're moving to a new location. So what we're trying to do is get to a state where like things look like. Can I ask folks to mute if they're not talking, just because I think we're getting somebody's background noise. Right, so like things look like, and we manage where we can to untangle some of that site specificity. That lets us do data characterization by comparing us to each other, and also by comparing our work to external sources of truth. Okay, I'm going to leave the content of this slide for reference and simply say that the OMOP Common Data Model is a way of structuring the data that's used by about now 60 or 70 different collaborating sites, covering, depending on whose estimates you use, somewhere between 700 million and about 1 billion people. It is optimized to store information about medical care delivered to patients, and in particular, it focuses on representing the same idea with the same terms, regardless of where it came from. Right? So if you look at the structure of the common data model, there are a lot of boxes here, but in particular, what we want to focus on is that the anchor concept is a person, and the health care that person receives, or the health status that person has. You'll see down the left the different kinds of health information that we focus on specifically. We'll talk more about that later. The other key is on the right. The columns that are the boxes that are in orange and purple. Part of what we do is we standardize the terms we use and the way we derive elements so that you can ask a question without having to know exactly how Seattle or CHOP or Cincinnati or Colorado answered it. Okay, I'm going to move on here because we'll talk more about that, and I want to give folks a chance to talk some about the vocabulary that we use. So I'm going to pass off the mic to Connor in talking about the CDM vocabulary.
Hey everybody, so I just want to go through the vocabulary tables that we have in our CDM. So first off, just about every idea that we capture in our database is associated with some notion of a concept, and so we index those concepts with concept IDs. So this really encapsulates everything like conditions, drugs, et cetera, and in order to really work with them, you have to understand the vocabularies that they come from. So some examples are SNOMED, ICD, RxNorm, but also broader ideas that also show up in our database, such as gender, race, and ethnicity. So the three main tables that we work with in these vocabularies are the concept table. So the concept table is really more of a dictionary of everything that's going on in our database. So it really tells us a lot about if we ever have any concept that we want to learn more about. But this is where we go to. It's a reference, and it teaches us the vocabulary that it came from, the domain that it refers to, and any other relevant information. It gives us a textual description of that concept. And so it's something that we're pretty much going to use in any sort of analysis. Concept relationship is another table that we use a lot. If you have a concept and you want to figure out if there's any other concepts that have some sort of relationship to it, a mapping from one vocabulary to another, for example, then this is the table that you have to go to. It semantically defines those relationships, and it's something that we use a lot in order to build a very thorough code set. A concept ancestor table is, it really captures the hierarchies that exist within the vocabularies that we work with. So for example, in ICD, there's all sorts of hierarchies with the codes that you can work with, and so those are directly captured in our concept ancestor table. But you'll find if you're ever trying to build a very thorough code set that there can be some very specific notions that are descendant to broader ideas. And I'll get more into this later. So a quick overview of the concept table. So first off, we have the concept ID that we're concerned with. And then of course, the description, which in this case is asthma. And then the concept code here is the code that comes directly from the vocabulary in which it was defined. And that vocabulary is also provided in this table. So here, in this case, ICD-10. And then from there on, there's also the domain ID. So in this case, asthma is a condition, and we can get some additional information. So for example, the standard concept tells us whether or not that concept will show up in our regular table. So for example, would this show up in the condition occurrence table? Beyond that, there's the things in red are specifically whether or not a concept is still valid. So for example, if the invalid reason has some sort of textual description as to why we would no longer use that concept, then that would not be null. And then the dates provided here also give us a notion of whether or not that concept is still valid within its vocabulary. So the concept relationship table is something that we use a lot. So for example, if we had to go from ICD-9 to SNOMED, then this is the table to do it. So you can see what's listed here is the relationship ID. And so that semantically is telling us that one concept, in this case, unspecified asthma, uncomplicated, maps from ICD-10 to SNOMED. And we know that this is a mapping because the relationship ID is filled in as maps2. And so you can see that in both cases, the domain is conditioned. And so we know for a fact that we are going from one idea that's just expressed in a different vocabulary to another. The concept ancestor table is also very useful in just about every study that I've ever worked on. And so what we see is that we have a hierarchy that's implicit with each, implicit or explicit in each of these vocabularies. And so if you need to know something more specific about a condition, such as asthma, versus asthma specifically diagnosed for someone with a specific age, or something a little more specific, such as like severe chronic asthma, then this is the table to tell you exactly how one concept hierarchically relates to another. And so we have an example of that here, where we see that uncomplicated asthma has a descendant within the same vocabulary of uncomplicated allergic asthma. And the degrees of separation are also listed within this table, so you can understand just how many steps you have to take to get from one concept to the next. And so we really have in these three tables just about every reference that we would need in order to get from one notion to another, and really encapsulate the relationships that are defined both within the vocabularies that provided these codes to begin with, as well as a methodology in order to expand any given list of concepts that we have. And so here is just a quick reference for the vocabularies that we have in each of our tables. You can see that some have more than others, and we'll dive into each of these in future slides.
And so let's pause there for just a minute, because I know we're going through things quickly, but particularly for folks who are not sort of immersed in the data model, what questions do you have about the vocabularies? Because these are a key building block to formulating any query. All right, so I'm going to throw an important concept out there that'll come through in the later sections. Remember, I was talking about the data model standardizing representations, and Connor finished by talking about standardized vocabulary. So what the CDM prescribes is that in the database, you will only ever see a standardized vocabulary. So like if we go back to the previous slide, what that says is the standard vocabulary for condition occurrence, for diagnoses, is SNOMED. So that means that every diagnosis in PEDSnet from whatever source, whether it started out its life as an ICD-9 code, an ICD-10 code, an IMO term, a Cerner vocabulary term, whatever, will be represented as a SNOMED code. And so when you're thinking about how to collect a data set in response to a request, you have to know that, and you have to make that translation using the maps to relationship. Because if you try to look up the ICD-9 codes, you're not going to find anything. Does that make sense? All right, so everyone is either asleep or nobody can hear us. I'm not sure which, but as we press on through the discussion, hopefully that will come into sharper focus, right? So we talked about how we store the data. Let's talk a little bit about where we store the data. I'm going to pass off to Kim to give us a summary of that.
All right. So now that you have a background in the vocabulary used throughout our common data model, we're going to talk a little bit about what else is in our data model. And I think a lot of you have experience with putting EHR data into the data model. So we're going to speak a little bit from the other end of how do we use and analyze the data that we have. So in our data model, we have a person table and some fact and observation tables, as well as the vocabulary tables that Connor just spoke about. And a lot of our fact tables in our database contain clinical information, capture clinical information about that person in the healthcare environment. And they use a common format. The fact tables use a common format where each row in the fact tables are a different occurrence of whatever that table is. So in the visit occurrence, or in the visit table, there's a distinct row for each patient visit. Or in the condition occurrence table, there's a distinct row for each patient condition. So you'll see that theme throughout our entire common data model. And the whole data model is central around this patient experience. So this person ID that's found in the person table is a foreign key into all these other fact tables where you can find information about that patient moving throughout the healthcare system. So this provides just an overview that you can look back at to see that the person really is central to the whole data model. And you can find that person ID in this condition occurrence table, in the drug exposure table, so that you can track their experience throughout the system. And this is also just a slide for your reference that shows the standard fields in all the fact tables. So you can see that there is the domain ID, which is usually the primary key of the table, and then there are all these other IDs. So as Connor was speaking about, concept IDs tie back to that concept table, which he was speaking about, but you would find different condition concept IDs in, for example, the condition table that you could then look up in the concept table. So this is the format that we're using throughout the presentation, so I'll kind of explain what you're seeing here so that you can understand as we carry through the presentation. So all these red rows are either the primary or foreign keys in the table that we're showing to you. And then these purple rows are kind of the meat of the table that are distinct to that table that we're talking about. So for example, in this person table, you can see that the primary key is that person ID, and all of the information in this table is about the person. But then these purple rows show the different demographic information that we're showing about that person. And each row in the person table is a distinct person. So even though that person will have many different visit occurrences or procedure occurrences throughout the data model, they will just have one row in this person table, and it's kind of your lookup table for each person in the data model. And this is another example of one of the fact tables in the common data model. So the visit occurrence table captures all of the patient's visits. So again, you see that person ID in there because one person can have many different visits in the healthcare system, but you can find in the visit occurrence table different information about that distinct visit. So each row in this table is a distinct visit for all of the patients. So these clinical tables capture information, like I said, about the patient experience in the healthcare system. And each row in each of the fact or clinical tables is a unique observation of that concept for the patient. So for example, some of the tables that we have in the data model are the condition occurrence table, which is diagnoses, and you'll see we also have a table for procedures and drug administrations, immunizations. So these are the different tables where you'll really find that clinical information about the patient.
Okay, does anyone have any questions about the general structure of the data model there? I think this is the point where we're supposed to say, remember, there will be a quiz. Two real take-home points there. Right? One is, for the most common kinds of healthcare, you'll find a special table that's got that kind of information, right? So for visits, there's a visit table. For diagnoses, there's a condition table. For drugs, there's a drug table, and so on. There's also a table called observations, which is where everything else goes. Right? The second thing is, remember those vocabularies. So when Kim was showing the person table, for instance, the person's gender, sex is what we actually have, race and ethnicity are represented by concept IDs in that. So you can't look in the table for male or female or M or F or boy or girl or that in any of a couple other languages, right? You're always going to see 8507 or 8527 because those are the concept IDs that correspond to the standard way we represent gender and so on. So as you think about writing queries here, everything you do is going to include these concept IDs.
So I think conditions will kind of take it a little less abstract and give you some very clear-cut examples. So let's get into it. The codes that we look at for conditions they all originate from either the ICD or SNOMED vocabularies, but our table is based around the SNOMED vocabulary. And we prefer that because it has more of a clinician base than any sort of billing code base. And so, next slide, please. I think just kind of taking a quick glance at it, we see that within the condition table, the most prevalent conditions are actually things that we may not actually consider a condition. So something like a patient encounter status is not something that I would necessarily consider a condition, but there's such a broad reach from the original ICD codes that have mapped into the SNOMED vocabulary that we do see a lot of these sorts of billing needs showing up. And then within this table, we also see that the first thing that might actually be considered a condition is probably the fourth most prevalent, the acute upper respiratory infection. And even within that, the two well-child and well-child visit condition concept IDs are pretty similar. And so we see that there's a lot going on in this table, and that has a lot to do with whether or not something originated from a billing code and was mapped to the SNOMED vocabulary, or whether it was directly derived from EHRs. So to give a quick overview of SNOMED, it's again very useful for pulling information from EHRs. It's specifically designed to be more appropriate for a clinical setting. The concepts in it are concept codes from the vocabulary table, the concept table in the vocabulary part of our presentation earlier. And so these codes are distinct to the condition that you're looking at. They're generally these very long series of digits that I'll give us some examples of later, but one quick note I'd like to make is that if you ever do work with these concepts and you have a very long stream of digits, you want to make sure that things aren't getting compressed into scientific notation or anything like that. But moving along, the descriptions are, sorry, previous slide. So then we have the description of the concept itself. So the actual condition, and as well as relationships that are provided by SNOMED to other concepts and the condition as it's described. And I'll show you an example of this later. But overall, SNOMED is a very broad vocabulary that covers a lot of things, but we find it particularly useful for our condition table. And so this is a quick schematic to kind of help illustrate that, again, we have this concept code, which branches out and shows us relationships between other concepts and the full description of that concept itself. But I think the most useful way to understand how this table is constructed and what we're looking at is to actually go to the SNOMED browser, which is linked below here. And you can see in this example that this condition has relationships that are shown to the right, where we're looking not just at the condition itself, but the finding site and the morphology, and kind of breaking into those components. And that has a lot to do with the parents and children that are listed here, which should echo back to our concept ancestor table. You also have again, of course, the textual description of the concept itself and the code that's provided. So if you ever want to go look up codes or understand more about a code, I encourage you to look at this website and just try to get a good level of familiarity with it. So another quick comparison, again, SNOMED is very terminological. It's very focused on a clinical setting, whereas ICD is, again, focused more on billing. It has it's very focused on its hierarchy, and there's no necessary relationships between terms or classes. So, but overall, you'll have to probably work with each of these, and you should consider that ICD had a large part in mapping to the SNOMED codes that are ultimately in our database. Okay, so, and then in this slide, what we're seeing is to the left are a bunch of SNOMED codes. They're listed as ICD-9 because they were mapped from ICD-9 to SNOMED. And to the right are SNOMED codes that were just pulled independently. And so we see that both have a fair number of counts in the database, but the ones to the left are a little more general, whereas the ones to the right are a little more specific and talking about more appropriate clinical terms in what we may actually think of in a condition. To give a quick overview of the table.
Connor, I had a quick question on the previous slide. I'm sorry. Is that okay to interrupt?
Of course, of course.
Awesome. So I'm looking at this, and this gives me a little bit of pause, and let me know if my assumption is completely off. When I look at these counts, these are from our PEDSnet data set right now, right, across the 8 hospitals? Or are these
They're about 3 years old, but yes.
Okay, but from our data set, right? It's not a generic from the vocabulary.
Right.
Okay, so what I'm seeing here though is then that majority of the hospitals, and Seattle is one of them, is sending more ICD codes than SNOMED because the mapping is probably non-existent, or they're doing a mapping from ICD to SNOMED. Is that a fair assumption? So
I think that was an accurate assumption at the time. And this was a slide that we recovered from a study where basically we looked at the database, and you're right, a majority of the hospitals at that point were mapping through ICD because that's how their billing data went. Those terms turned out to be useless for the execution of the study. And right. Only the records that had the codes on the right were valuable to the investigator because he needed to know what kind of brain tumor the patient had. And so since then, as the ETL folks know, we've gone back and we've asked hospitals to source their data so that they give us both the direct mapping to SNOMED and the ICD mapping wherever possible. So if we did this query again today, we'd see many fewer ICD equivalent codes and more SNOMED equivalent codes.
Yes, okay, perfect. Thank you for that explanation. That's what I wanted. And Seattle's hopefully getting there someday. I still have sleepless nights on that, but okay.
I hear you. I hear you. And I think most of us do it in part, and the more places we can get there, the better off we are.
Oh, absolutely. But thanks for the explanation.
You bet.
So just a quick overview of the condition occurrence table and what's actually in it. So the condition occurrence ID is the primary key here, and then we have foreign keys for person ID, visitor occurrence ID, and provider ID. That's because, of course, if you have a diagnosis made, you want to know who it was made on, who gave that diagnosis, and what the visit was that's associated with it. Then we get back to the vocabulary with it. The condition concept ID is, in this case, a concept ID that you could look up in the concept table that tells you what that diagnosis is. The type concept ID is referring to the header, the type of visit that this diagnosis is associated with. And then we get into dates, and dates are more or less going to boil down to, in most cases, the condition start date for me, although there may be some instances where you want to look at the condition end date as well. And those are in both date and date time. The POA concept ID is just whether it's present on admission, was that diagnosis already there? Stop reason, why was that condition no longer present? And the condition status ID, which is whether or not it was a final diagnosis. And so this is where you really start getting into code set creation. So more often than not, when you're working with an investigator, they're going to provide you a list of ICD codes. That's what a lot of them are familiar with. And so you have to find mappings that will go clearly to SNOMED. And so this is where the condition or concept relationship table comes in handy. But it's also, of course, very important to go through SNOMED and see if there's any independent SNOMED codes that you can find in the database that may not have been mapped directly from an ICD code. And so here we actually see in the, So, and here we actually see in SNOMED that some of them actually had the same name, but that's because they were mapped from different ICD codes. But overall, we do see kind of a consistent idea of what was said earlier, that the ICDs are generally less specific, whereas the SNOMED is more based in clinical terminology. And of course, the concept ancestor also comes in handy. So in this example, we have muscular dystrophy. If you have a very broad concept ID for muscular dystrophy, and you may want to just investigate various types of it without any sort of discretion as to what subsidiary type it is, you may just go straight to the concept ancestor table, plug it in as the ancestor and find all the descendants. But of course, in many cases, you'll still have to filter through those. So for example, if you have a drug that you only want to look at oral tablets for, then you'll probably have to continue to look through and make sure that you're not grabbing anything that you don't want.
Okay, which sets me up greatly, really well to talk about drugs. But again, let me just pause and ask, what questions do folks have about how diagnoses are laid out?
So, Charlie, this is Daksha. My question is about the concept ancestor table. Is that something that PEDSnet does of the data after we send it, or is that not used right now?
So it comes mostly from the National Library of Medicine, and what it's doing is advantage of the parent-descendant relationships in these terminologies, right? So what we're hoping is that folks send us the bottom levels of that ancestry, right? So, you know, if the clinician put a diagnosis of Duchenne, then we try to get the code for Duchenne. But as Connor said, if you wanted all muscular dystrophies, then you could use that concept ancestor tree to say, I start at muscular dystrophy, can I have all of the types?
So it's more of a lookup table than actually that making the assumption that the patient has all of the others.
You got it. It is.
It's exactly it's to find more. It's to find more ends if you need to of like disorders rather than you going and searching each one.
Right. Right. It tells you so concept ancestor tells you about specificity, more less specific, more specific. Concept relationship doesn't so much do that. It helps you hopscotch from one terminology to another. So ICD to SNOMED or NDC to RX norm.
It does have one level of hierarchy, like it has like the relationship
it's
ID
in there,
with
but
the
you would never use it.
But it does contain that, but it doesn't go through all of the different branches and, you know, show it as extensively as a concept ancestor.
Okay, I got it. So then as a researcher, if I'm looking for Duchenne, but I also want to know any more specific codes related to that, I could use that table and then choose the whatever I want from that in my query set.
You got it. Exactly.
Yeah, perfect. Thank you. That really helps.
Sure. Were there other questions about diagnoses? Okay, we'll get into what kind of...
Oh,
go ahead.
Sorry. This is Suzanne McCann.
Sure.
I am not real familiar with what gets put into the medical record. Does it, at some institutions or hospitals, does it end up to be a very vague definition, even though the patient could have a more specific diagnosis?
Yeah, so there's honestly a lot of variety. Most of the time what happens is that the clinician puts in a moderately specific diagnosis. And if you're a geneticist, then you're putting in really specific diagnoses. If you're an ENT surgeon, you're probably putting in mid-range. And then behind the scenes, those get mapped to less specific billing codes. You know, the ENT surgeon might put in, you know, acute suppurative otitis media. There is a more specific code, acute suppurative otitis media of the right ear, but they don't usually do that. Behind the scenes, that'll get mapped to a generic billing code like otitis media, right? But we try to capture in PEDSnet that more specific code so that if you're studying acute otitis media, you can tell.
So both the diagnosis and the billing code are in the medical record.
Yes, and if you look at, we'll go into this in a future session, but we actually ask sites to capture both so that you can look at either perspective on the data.
Okay, thank you.
You bet. Okay, so let's talk about medications, which are going to sound kind of similar in their structure to conditions. So there's a little bit of a variation in convention. The table is called drug exposure, not drug occurrence. right? But this records every time we do something in the health system about a drug, and it's so it could be in a clinic writing a prescription. It could be for an inpatient, every dose that's actually given to the patient. The vocabulary of choice here is RX norm, and we'll talk about that in a bit. And that will be consistently used no matter where the drug record started from. We do capture, in addition, some details about the drug. We try to capture dose and frequency, refills, that sort of stuff. Those fields have variable data quality, and that's because the data are coming from different places. So if it's coming from a dispensing record, there will be very little data about the visit context because they just know the drug left the pharmacy. If it's coming from a prescription that's in an EHR where you click buttons, you will get things like the dose and the frequency. If it was one of those type into the box here EHRs, you won't. And so you have to be careful about the quality of that. But let's talk about what drug you're taking. So the reason that this data model uses RX norm is that, kind of like SNOMED, this is a terminology that is intentionally designed with with levels of specificity, so you can decide what you want to look at. Right? At the root, when a drug is given to a patient, you have a lot of information. You know what the active ingredients are, you know what the strength is, you know whether it's a liquid or a solid, you know whether it was given systemically or put on the skin, and if it was systemic, whether it was swallowed or injected. So you can start with a drug code that says, naproxen 250 milligram oral tablet made by Teva, right? And that's actually what the patient took. And any of those things might be important to you in a particular study. If you're looking for contamination of the drug, you need to know it's the Teva product and not somebody else's. If you want to know what the dose is, you want to know how big the tablet was. But sometimes you just want to know who took naproxen or who took naproxen enterally. So what RX norm lets you do is walk your way up and down this hierarchy, right? And you can see here, down at the bottom are purple things that have to do with branded drugs, where you care about who made it. And up at the top, more often in that orange color, are information about what the pharmaceutics of the drug are, right? What are the ingredients? How did you take it? What's the strength, right? So if we click ahead, we can look at how these things fit together, right? So this is using an application that, again, the National Library of Medicine puts out that helps you kind of get a sense of how these terms relate to each other. So this is what happens when you ask, tell me about amoxicillin. You can see that there are 14 different drugs that have amoxicillin in them. So what combination you want may differ from study to study, right? You can also see, as you look down the left column to things like clinical drug or PAC, what you give a patient is actually a particular size tablet or a particular strength liquid, and we can represent that. Sometimes we can tell you who made it, and that's the branded column. Right? If you look at the data in PEDSnet, what you'll find is that the majority of the time, we're sort of down further on that hierarchy. Before we get there, I also want to point out one other thing about the drug representation. So the drugs themselves are always in the vocabulary RX norm, but there are some other ways to describe medications that the CDM vocabulary lets you get to. This is showing one called the ATC class, right? So again, if you look at amoxicillin, that's an extended spectrum penicillin. That's a systemic antibiotic. And so again, if you wanted to ask who is taking an antibiotic, you could start with antibacterials for systemic use and look at all of that concept's descendants to try to figure out if you've got the set of all antibiotics. If you wanted to know who is taking a penicillin or a penicillin-alike because you cared about allergies, you might start with the class of penicillins with extended spectrum. So ATC gives you drug class, NDFRT gives you uses, drugs you might take for high blood pressure, drugs you might take for constipation, that sort of thing. So as you're executing studies, you can use these other concepts to get groups of drugs together. The data themselves are represented in the table similarly to diagnoses. So there are the keys up top, right? A unique identifier, who took it, who prescribed it, when it was taken. There are the ways you get at what drug is involved. So the drug concept ID tells you what the drug is, amoxicillin or prednisone or etanercept, right? The drug type concept ID tells you where it came from. So this is where you would look to see, is this a prescription or is this a drug given to an inpatient? Just like a condition type concept ID is where you look to say, is this an outpatient diagnosis or an inpatient diagnosis? There are dates as usual, and then there's that big orange chunk of information. How much was the patient taking? How long could they take it? How often should they take it? Those sorts of things. These are the places where the quality varies based on where the data came from. And then additional data that you probably won't often go into, but we can circle back around to. Okay. I talked about the variability in how specific you want to get. So you can see almost 90% of our drug data are at the level where we're telling you what product actually went to the patient, with or without a brand. We're saying amoxicillin 40 milligram per milligram suspension, or we're saying prednisone 10 milligram tablet or better. The remaining 12–13% of our data give us less information, so that the SBDF and SCDF at least help you know whether the drug went into the patient or onto the patient. And then the concepts above that bottom block where we find 8% of the drugs, just tell you that the patient and that ingredient came together somehow, but we don't have a whole lot of information about how it got to the patient, and you need to use other data in the table to get there, like route or some more arcane techniques we'll go into in a future session. Okay. So that's what the data look like. Then the question is, how do you use it? Not surprisingly, as you go down that hierarchy, the number of codes increase, right? And what we're saying here is, if all you care about is that the patient came into contact somehow with the ingredient prednisolone, you didn't care if it went on the patient, down their throat, into their veins, into their lungs, you only have to start with one code, and you just say, give me all the descendants. But as you step down the list, you get more and more information. So there are 40 different ways you can take prednisolone. Some of them are oral liquids or injected solutions. And at the bottom of the list, there are 423 different actual drugs that could come off a pharmacy shelf when a patient was taking prednisolone. So we're going to use the hierarchy in Concept Ancestor very often to build these code sets. And in particular, you're probably going to start with what's called a clinical dose group or a clinical drug form. And those are both things that give you information not just about what the drug was, but about how the patient took it. That's typically the right place to go, because typically the study design is going to make some assumptions about the type of exposure. You know, if you're studying steroids for asthma, you probably want to distinguish between steroids that went into your lung and steroids that were systemically administered. And you probably don't even want to think about the hydrocortisone that the patient was putting on their eczema. But if you just start with steroids, you're going to get them all. So you want to pick the right level. On the other hand, typically, you're not looking at studies that say, I only care about people who took 10 milligram tablets, right? Unless you're doing safety studies of a particular drug. So you don't want to start there. Cool. All right. So what questions do folks have about drugs or the way we represent drugs and how you would use that to develop code sets?
That was really good, Charlie.
Thank you. I'm glad it made sense.
It did. My other question, but I'm going to table that right now because I myself don't understand all the various multum, RX norm, NDC, and then how accurate the mappings are, which I know is not the point of this discussion. So those are the things that are going on in my head.
You got it.
Granular to my level.
Right. I will say broadly, if you start with a granular code, you start with a granular NDC code or GPI or Multum code, the mapping is really good. It's when you get to less specificity that the mapping gets kind of fuzzy.
Yep. And so then I have another question that really brought up a different question is how for something like a common data model, how do you address custom mixtures that are very specific to a given hospital formulary?
Yeah, tricky one. So what we ask people to do in the ETL process is take the mixture record and generate a row in drug exposure for every component of the mixture. The caveat there is we don't necessarily ask for a row for the carrier. But if you have a mixture of doxorubicin, vincristine, and etoposide, we're asking for 3 separate rows in drug exposure for each of those active ingredients.
Okay, but then how would we link them together? I don't know if you do that.
It's tricky. There are 2 ways to link them together. One we'll get to in a future session. There's an actual link in the data. But more commonly, if you see that all 3 drugs are given at exactly the same time.
Yeah, at the exact same time.
Yep.
Doctor, this
but
is
that
also
itself
where,
can have some faults.
Yeah, this is also where we make heavy use of the drug source value.
Yeah, I think ours goes in the source value.
Yeah, I think a lot of people have trouble even being able to separate the 3 because it's often like one thing in their EHR.
Yep.
So I think, sometimes we have to go to the source value and do some string searches.
You got it. And we'll show you how to use source values in a later session.
Yeah. Okay. Perfect. Thank you.
So looking at procedures, I'd say generally procedures are a little bit easier than the other tables with some nuances. So we have a very broad definition of what a procedure is in our database. So something like a surgery is pretty hard to argue whether or not it's a procedure, but then there's more administrative stuff and testing that it is also considered a procedure. But the one thing you can be guaranteed of is that in our database, our procedures are completed orders. The procedure table also spans a couple more vocabularies than the other tables. So the most prevalent is the CPT, and followed by the HCPCS. But you'll more likely than not also have to deal with ICD procedures and possibly also SNOMED procedures. The procedure table can also spill over into other tables. So like I said, there's completed orders in the procedure occurrence table, but if a procedure is something like a lab test, then the result of that test is going to be found in the measurement table. Another example is something like an infusion, which is a bit of a pseudo-diagnosis, will actually show up in the condition occurrence table. So if you're looking at something that you know is going to span one of these areas, then you're probably going to have to investigate these additional tables in order to get all the actual procedures you're after. A quick overview of the procedure table. So the primary key here is the procedure occurrence ID, just like the condition occurrence ID. The foreign keys are the person ID, provider ID, and visit occurrence, because again, you want to know who had the procedure, who provided it, and what the associated visit was. The procedure concept ID is another concept ID where we're learning, again, what the procedure is that was performed. And then the rest of the stuff in blue is stuff that you may or may not work with a lot, but it can provide additional information about that specific procedure. And the date you want to look at is the procedure date, which does not have an end and a start and end time like in other tables. So in code set construction here, again, you want to remember that it can spill over into other tables. So if you're looking for labs, make sure you're looking at the measurement table. And if you're looking at pseudo procedures, you want to look into the condition occurrence table as well. Bundling, so if you have a set of labs that's performed as a procedure, it will only be one procedure occurrence in the procedure table, but those results could span multiple rows in the measurement table. So be aware of that if you're looking at things like counts or aggregate information. But overall, the procedure occurrence table doesn't follow as explicit of a hierarchy, although you can use the concept ancestor table with it. And so here's an example of that, where we're looking at one specific type of procedure, the computed tomographic colonography, and finding descendants associated with it. But again, we see that this is a very long textual description of the procedure that's being performed. And in general, the concept relationship table is its role is a little more ambiguous here in the sense that there's multiple vocabularies in this table, but I still think it's useful for investigating whether or not there's additional codes that you should be looking at. And here is just another example of if you take a procedure concept and you look at all the descendants, just how many can you find? And you can see that there are many with subtle variations.
Any questions about procedures?
Hi, this is Ryan in St. Louis. This is actually a question that's just been in the back of my mind for a long time when working with the procedure data. In a condition occurrence, we crosswalk everything into SNOMED, and we use RX norm and the drug exposure. And I've always wondered why we don't do that in procedure into CPT or something like that. Does it just not lend itself to that in the same way?
That's it in a nutshell. You know, for the former two, SNOMED and RX norm are committed to spanning their entire domain. So, you know, what happens is when the FDA creates an NDC code that wasn't an RX norm goes out and creates a term for it, right? Okay. So that is guaranteed. The AMA doesn't do that for CPT. ICD doesn't do that for ICD because they have a particular use case in mind. And so we end up with this kind of gamish because there may not be a good CPT code to match a particular surgical procedure. And you can almost bet there won't be an ICD code for a laboratory test. So, you know, you get these domains where a particular terminology has good coverage, and we do map there. So, you know, if there is a CPT code that describes it, we'll map to that. But if you look at the table as a whole, the things that CPT doesn't reach may land, you know, may stay in ICD and so on.
Makes sense. Thank you.
Sure.
Charlie, do you think historically CPTs were for something that happened for a patient versus ICD to a patient? So how I have been understanding it, and things have gotten quite better in cross mapping the two, not complete as you said, but ICD is mostly in the inpatient setting where you do a procedure versus CPT is more procedural. I know I'm calling it both procedures, but office visit, for example.
Yeah, I think that nails it, right? That CPT has historically been for provider billing and ICD for facility billing.
For facility, yeah.
Okay, great. So we already spoke a little bit about how procedures can relate to measurements, but we're going to speak to measurements as a whole. So the measurement table captures discrete results of procedures. So this can include lab testing, it can include anthropometrics. There are also some measures that the DCC derives after we receive your data. So for example, BMI scores are, BMI-Z scores are computed after the data is already in the data model. So measurements, similar to how procedures can be found in different domains in the data model, measurements can also be found in other places besides just the measurement table. So usually if you were looking up different lab values, you would want to go straight to the measurement table. And the measurement table includes, or there are other divisions of measurements such as measurement labs, measurement anthro, measurement vitals, which are other tables that are not really used as often as the measurement table, but they are different places that you can look for different values. The observation table also has a little bit more of unstructured measurements. So for example, if there were different survey results that are technically measurements but don't fit into the measurement table, they might fall into the observation table. And then, as Connor mentioned, some procedure occurrences. Procedure occurrence captures some measurement values as well. This is an overview of the measurement table. As you can see, the measurement ID is again the primary key, and there are foreign keys to the person table, visit occurrence, and provider. And the concept IDs in the measurement table are the measurement concept ID and measurement type concept ID, which specifies where the measurement came from. And then there are also dates of this measurement and other metadata about the measurement. And this is a continuation of some other information that you can find in the measurement table. So for example, operator concept ID, value as number. So different parts of the measurement that you still want to include that might not be just that one value or numeric value of the measurement. And there are also range high, range low. So if that measurement does have different range values to compare that measurement value to, it might also go in this measurement table. So typically measurements are in the LOINC vocabulary, but there are also some SNOMED or, like I said, PEDSnet vocabulary for things that are derived after we receive your data. And no, I was just going to mention that there isn't really a formal hierarchy for LOINC vocabulary.
We're working on building one, but nothing yet.
But yeah, a work in progress, but it's not as straightforward as mapping ancestors and descendants and finding different relationships between the LOINC codes. So also, the measurements that are captured in this table are at the component level and not the panel level. So you wouldn't be looking for a basic metabolic panel in here. You'd be looking for an individual component, so maybe a creatinine level or glucose. But as you can see, even something that might seem simple like glucose has 60 different values. So you'd have to take that into consideration when you're building your code set. You wouldn't just be looking for one concept ID that represents glucose.
And I have to say there is a bit of a spread because we are accepting from hospitals an internal LOINC code, and it may well be that, say, CHOP and Nationwide and Seattle all pick different codes out of those 60 to mark their serum glucoses. So a little more work involved in code set construction there. What questions do folks have about measurements or lab results?
This is Suzanne again. You mentioned that glucose has a lot of codes that can be used to measure it. Are there other, is that typical of lab measurements, or is glucose an unusual one?
It's rare in our experience to find any measurement that has fewer than 4 or 5 codes. Glucose is particularly broad, and some of these codes are not glucose itself, right? You can see that there's a bunch of G6PD codes, for instance. But if you searched on glucose, you would find them all.
Okay, thanks.
You bet.
Okay, so the next section, we talked a little bit just generally about how these tables are structured and the main tables that we use. The data model contains some more tables, and we'll go over those as well. But that provides kind of a general overview of what those tables are and the semantics of them and the terminologies that are used. This section is going to talk a little bit about the specific standards or how we've kind of adapted OMAP to fit PEDSnet needs and how that works. So the ways that we've done that is, we've expanded value sets. Most recently, the field visit concept ID in the visit occurrence table, for example, typically in the typical vocabulary was just inpatient, outpatient. It was pretty broad, and what we realized in our use case was that not only were we interested in face-to-face versus administrative visits, but we were interested in face-to-face with a physician or another sort of face-to-face that was just like an interaction with the lab or radiology. So we've gotten pretty granular with some of the value sets that we have. Another one, specialty concept ID, is actually completely missing in OMOP for the care site table. We went ahead and added that in. We added tables. ADT occurrence is a flag for ICU. Immunization is immunizations, which is completely missing from OMOP because we are more child-centered. Measurement organism, we added for specific blood culture results that it didn't get to the level of specificity of the measurement table that we needed, so we created a separate table. And then when we get the tables from the different sites, the DCC creates like these different lookup tables to be able to do code set searches a little bit better. And so we'll go over this a little bit later when we talk about how to construct code sets, but this is really looking at all the distinct source values to be able to do string searches or to be able to explore how, if something looks funny in the data, or if we want to see what was in the source a little bit better, to be able to do those kinds of mappings. As Kim mentioned, we do partitioning here. So we have everyone sends us their measurement table, but because the measurements are kind of semantically different, we have vitals and labs and anthropometrics. And because each one of those are kind of huge, we've actually partitioned those tables into 3 separate tables here to run our queries for more efficiency. And then we do the data derivations, as Kim mentioned. We derive z-scores, for example. We've also used the source value. So source value in these fields, in these different tables, are meant to kind of represent what's in the source structure itself that people are pulling from. And we kind of are leveraging these tables to maximize the information sent to us. So for example, in the condition table, we have the condition concept ID, and as was mentioned before, those are all standardized to SNOMED. What our source value field does for us is give us the IMO code from Epic typically, so that's the proprietary code from Epic, and then also, most importantly, the one that we use the most is the ICD code. And again, we use that a lot because people are very, very interested in billing data. So it's very, we pull both the SNOMED code for the condition concept ID, but if we need to go back and see how the mappings are, what that turned out to be in billing, we pull this in the source value. And then the source concept ID is the standardized concept that matches the ICD or ICD-9 or ICD-10 code. So this is a way for us to kind of pull information and understand how the source might be informing the code sets that we find. So this, we do similar things. I won't go into detail, but we do similar things for the drugs and the labs to be able to, we have an order of which, the source values and source concept IDs should be represented. And this is really when in later sessions, when we get into code set construction and really going through how to fulfill a query and working with investigators, these fields help us to debug a little bit. It helps us to understand how the ETL process may or may not have changed the life cycle of a code over like the standardization process, and it gives us insight into what sites might be doing or might not be doing to derive their code. So, so that's another thing that we do at PEDSnet. So I'm going to pause there. Are there questions about that? Okay. Sorry, go ahead.
Okay. One thing, and we'll talk about this in request fulfillment. Just one thing that Merritt's mentioned a number of times is that people are giving us source codes and as text values, which is very helpful for us internally for debugging. Part of the governance of the network is you don't give them out to people. So as investigators come from your site and say, hey, we're interested in X. As you build your code sets, it's fine to look at things like source values, but you can't give them out. And specifically, you can't give them out because we don't have a guarantee that they don't contain PHI, or for that matter, provider identifying information. And that's also part of why we use standardized codes.
Okay, so the data models presentation, we went through kind of the standardized tables, the tables that we use the most, condition, procedures, drugs, measurements, etc. And I mentioned in some of the PEDSnet adaptations that we've made, such as ADT occurrence, immunization, measurement organism, we have some additional tables. There are some other additional tables that are provided to us by OMOP as well. So observation, visit pair, error tables, care site, and provider are all within the OMOP CDM that we use. So the data model additions, as I mentioned before, the measurement organism is it's specific to laboratory culture results. So it'll take a measurement test, like some sort of blood culture, and then it'll the measurement organism will say like if it was staph or something else. And so it gets more specific when you need that information. ADT occurrence is for inpatient visits. It will tell you whether a patient was transferred to the ICU. So there's a foreign key visit occurrence ID that goes back to the visit occurrence table. So you can link that back to see if that particular inpatient visit was also that resulted in a ICU stay as well. And then immunization the main foreign key is person ID, and it's usually at the person level. Some optional foreign keys, like if you know that an immunization was given during a visit, you can link it back to the visit occurrence ID, or if it was linked to a certain procedure, you can do that too. But mostly we look at this at the person level. The observation table is kind of our, it's a flexible table. What it does is it allows, it's normalized so that you can add in whatever other things that are just not quite captured elsewhere that you want to be able to capture somewhere in your data model. So what we have in the observation table is tobacco, smoking, and then birth information, because that, birth weight, for example, or whether it was a vaginal delivery or a C-section, these are things that they don't have good places elsewhere, and the observation table gives us enough flexibility to just kind of throw it into a table somewhere about a patient. So that's kind of the purpose of the observation table. So it's set up so that the primary key is the observation, whatever that instance of the observation, and then it has foreign keys to person, provider, and visit, if applicable. And then the observation concept ID is whatever you're measuring. So it could be birth weight, it could be smoking status, or something like that. And the observation type concept ID and qualifier concept ID are metadata fields around that. And then we have the date and date time, and then the results are given flexibly as well. It can be as a concept ID, a standardized field, or it could be a string, or as a number. So so this table allows you to pick the concept and then the result, however you want to give it, but it has less specific fields than in like the condition table or the procedure table or the more denormalized tables. The provider and care site tables we actually do use quite frequently when we're putting together queries and performing studies and things, and really we use specialty a lot, and we'll go into more detail about this, but the provider table generally contains provider metadata, including specialty, and like gender, and it has an MPI field that we don't require use, ethnicity, and those sorts of things. Birth year, I think, is in there as well, the provider. But like I said, mostly we use it to get the specialty of the provider. And then the care site is a similar field, except it's about the facility in which a patient received care during a specific visit. So when we do specialties, we're often asked, we want like if someone comes to us and says we want to look at type 2 diabetic patients, but we want to see how often they're seen by an endocrinologist. What we'll do is we'll pull both the provider specialty for endocrinology, but also if we know a certain care site is an endocrinology clinic or type 2 clinic or something like that, that would be in the care site table. And some sites are very, very good at providing provider specialty, and others are very, very good at providing care site specialty. So we use the combination. And then visit payer is the payer associated with a visit. So this is not like in claims data where you have enrollment information. This is just for a particular visit, that instance of the visit, what was used to pay. And we normally, so it's both plan type and plan class, and we normally just give it at the plan class level, and nothing more specific than that. And then finally, we have condition era, drug era, and observation period. Condition era and drug era are things that are derived at the DCC, and it's really just meant to look at, if a patient has multiple visits for a certain condition over like a span of several days, that's rolled into one. Or if you're looking at a certain drug that might have been given continuously, it'll be rolled into one until it looks for like a gap of like 30 days, so that you can see how long a patient was theoretically, continuously on a drug, or continuously seen for a certain condition. And then the observation period is basically first fact associated with the patient, last fact associated with the patient, so that we can see how long we have for a follow-up. Oh, I think that's it then. All right.
Great. So lots of stuff in the catch-all. Rarely things that will be the primary criterion for setting up a study cohort, but frequently things that will be important accessory criteria or covariates.
Are there any questions about these? Or anything in general?
Actually, a request. The condition era, drug era is really, really interesting. Would you mind sharing your code?
Yeah, we can definitely make that available to you.
Yeah, that would be amazing. I can see a lot of good use of that here. We've tried to do that and we do it, but it would be really good to standardize on that as well. And we can definitely learn from PEDSnet.
Sure, we're happy to send it. And I think actually OMOP or OHDSI, if you go to their GitHub, I think they also make their code publicly available that they use. And I'm not sure how much we differ or don't differ, but we can definitely put that up and let you know and send that to you.
Yeah, no, I think we would err on side of using yours, just so that, if we ever get some studies that cross, then again, looking for standardization and looking for how you're doing it would really help us.
Sure.
Perfect. And so that leads me to my second question, sort of, is you mentioned, and this was at the measurement, I think, or between, is OMOP, when they don't have a specific use case concept for PEDSnet, PEDSnet creates their own. Either it's a table or it's a field in a given table. Is it a two-way street? By that, what I'm asking is, do you then go back to OMOP and say that this is very useful? Can you add it so that it's made available across?
I mean, as far as I know, on Charlie Pipe, and we don't have a specific process in which we go and do that, but we have oftentimes given our input. I know, for example, the care site specialty ID is something, the specialty concept ID is something that we've brought up several times, and yeah, things like that. We go ahead and we communicate that, but yeah, we haven't like pushed, or there isn't like a formal process that I know of. Charlie?
So OHDSI has a kind of ongoing, when we need codes that we suspect somebody besides PEDSnet will use, we have requested them. They generally do get included in the vocabularies, and that's a pretty easy process.
Right.
The process for new tables in the data model is more of a kind of informal discussion. There is a working group in OHDSI, and we have proposed some tables. Some of them, because that working group is trying to level things out across a bunch of different users, we'll make a proposal, somebody else will make a proposal, it all gets kind of merged together. But the presence, for instance, of date time fields in all of the fact tables is because PEDSnet asked to have them there. The admission and discharge stuff, and so on. It's just that in some cases we have stuck to new table structures because we're the only ones using it, like the ICU flag or the organism data.
Right. Okay.
So I know they've been talking about having like a visit. What?
Yeah. So they adopted a table called visit detail.
Yeah.
That
in the next version, I think.
Which will cover aspects of that.
Yeah.
Again, based on the structure of the table we developed, but with some input from other folks who had different needs as well.
Yeah, like I mean, they're really open, but you know, whether or not they adopt something, and whether and not we're consistent about kind of going back to them and telling them what we've done is kind of not formalized.
Got it. Thank you.
Yep. Anyone else about anything presented? Thoughts, comments? No. Okay.
Cool. All right. Well, I know a lot went by. Any questions on not just content today, but on the way that the whole process works? Okay, I'm glad it's so clear. So what we will do in the coming week, we will do two things. One is we will get the recording of this session out to folks. So if there's a colleague from your institution who couldn't make today's webinar, we'd ask them to go through the recording and let us know so we can keep track of what pieces of the curriculum folks have gotten through. We will also, at the end of this week, send out the exercises based on today's presentation. So since this has a strong focus on the structure of the data model and vocabularies, those exercises are going to focus on navigating through the model in a more granular way than you might see later on when we would be taking more of a study focus. One of the exercises is going to be fairly easy, and that's going to be connect to and set yourself up in the virtual desktop environment where we'll be doing data analyses both in the course and afterwards as well. My hope is that everyone here has already been set up with access to that desktop environment. You'll know if you got an email from Cirrus at CHOP giving you the connection details, and it will have instructions for how to actually connect to the virtual desktop. Okay, then, if no one else has any questions.
I have two questions.
Sure.
One is, could you share the slides with us as well?
Of course. Of course.
And if we haven't been given connection information, who should we contact?
Suzanne, you can send me an email. This is Kim talking, but I think we're on the same page. I think Suzanne and I are working together. Or you're working with Raul, right?
Yes, yes.
Yeah, so I think we're squared away.
Okay.
This is Kevin from Colorado. So you said that email already went out with that access, and do you know when it went out? I'm just looking through my email and I don't see anything.
You didn't get it either here at Seattle.
Oh no. Okay.
Sorry, this was the first time I heard about the virtual desktop, but I'm dense, so.
Unless it went to your spam folder or something, when we were added, we got an email from RIS here. So it's possible that you got an email from CHOP IS sent to you. But if nobody did, then we can investigate that.
It will come from a very spammy sounding address, right? svccirrus@research.chop.edu.
Yeah.
We here in St. Louis haven't gotten it either.
Okay. All right. So it sounds like we've got some digging to do to figure out what made it out of the firewall. If folks would check their spam folders, that would be great, and we will also check to make sure that we've got everyone connected. If worst comes to worst, we'll just manually send out the connection instructions.
Yep.
Okay, that would be great. Thanks.
Thank you. Thanks, Charlie. This has been really, really helpful. Thank you. Even though we've been with PEDSnet almost from the beginning, to see an overview was really great. So
well, thanks. I'm really glad. All right. Well, grateful to everyone for their time. See you in May.